Hello, this is Ben Maynard presenting for the 5th Annual Michigan Summit on QI and Patient Safety. This is our project reducing overreporting of hospital-acquired C. diff infection by increasing accuracy of labeling. We are from the Wayne State University Family Medicine Residency. For some background, Clostridium difficile or C. diff infection is caused by a spore-forming bacterium which causes a diarrheal illness and can have complications such as life-threatening colitis, dehydration, and increase the burden of disease in patients with complex medical backgrounds. The estimated cost in the United States each year is greater than $1 billion and possibly up to $5.9 billion. Infections of C. diff that are acquired in the hospital are considered hospital-acquired C. diff and can be prevented. These methods for prevention include contact precautions, frequent hand washing, and reduction of transmission of spores. Accurate reporting of hospital-acquired C. diff infection cases is essential to get an idea of how bad the cases are in the hospital, how frequently they're occurring, and target methods of entry for new infections. Additionally, institutions with high rates of hospital-acquired C. diff infection lose money from Medicare reimbursements every year. We were reported that the 2018 to 2019 ratio of infections at Ascension Providence Rochester Hospital was higher than our goal. We hypothesized that our automated reporting system called Sentry 7 was over-reporting the number of cases. Our objective then was to reduce the number of hospital-acquired C. diff cases by reviewing these automated reports and making and implementing changes in how the reports are collected and analyzed. We reviewed the Infectious Disease Society of America guidelines on the definitions of C. diff, as well as the management and prevention guidelines. We compared these definitions against the Sentry 7 reported cases, and we then labeled each case as either confirmed, mislabeled, or indeterminate. We assigned 4 residents to review all cases of hospital-acquired C. diff from September 2018 to August 2019, and in total we reviewed 34 medical charts. Our metrics used for this analysis at the end was the number of incorrectly reported cases of hospital-acquired C. diff. For our results, we found that of the 34 cases, 16 of them were confirmed hospital-acquired C. diff according to the Infectious Disease Society guidelines. However, we found that 47% of the cases were mislabeled in some way and should not be considered hospital-acquired C. diff. Also, 2 cases were indeterminate, meaning they didn't fall clearly into the guidelines provided by the Infectious Disease Society, and we left them in their own category to not affect our results. We then looked further into each of the cases where this was a mislabeled case of hospital-acquired C. diff. The most frequent reason we found was something called a negative DNA amplification test. In diagnosing a patient with C. diff, a stool sample is collected, and as part of the sampling process, a DNA amplification test is performed. When this test is negative, this patient is not considered to have C. diff. We found that 56% of the reasons a case was mislabeled as hospital-acquired C. diff was due to this DNA amplification test. Other reasons were laxative use within 48 hours of testing. Patients who are in the inpatient rehab unit were counted, although these are not considered as inpatients for Medicare reimbursement. And an additional 2 cases had diarrhea on admission, which means by definition it was not hospital-acquired C. diff. Our QI tool was the PDSA cycle, including a planned step, which was to compare the standard infection ratio in the quarter before with the quarter after our intervention. Our intervention was to correct the process in the Sentry 7 system, to exclude cases with negative DNA amplification, and add a manual review step by the quality department personnel before submission. We implemented this process in November of 2019, and after studying our implementation, there was a 40% decrease in our hospital's standardized infection ratio, which is reported nationally and used for our reimbursement. Here is our pre-implementation standardized infection ratio, and here it is after the process, showing our 40% decrease. In the ACT cycle of our PDSA cycle, we adopted the new protocol, and in the future we will plan to adapt additional protocols for these other more frequent causes of overreporting, such as laxative use and diarrhea on admission. In conclusion, accurate reporting of hospital-acquired C. diff rates is crucial for hospital reimbursement. Computerized reporting systems can improve efficiency, but have a tendency to over-report hospital-acquired C. diff in our hospital. Institutional level policies, such as ignoring the DNA results, can identify and correct over-reporting. And then sufficient focus can be placed on prevention to improve patient safety. Our references are available in hyperlink format in our presentation. Thank you for your attention.